Okay, so I think I'll just start with some of the housekeeping that we need to run through before we start the session. So, welcome everybody. My name is Karen Creed, and I'm lead midwife for genomics at Central and South Genomic Medicine Service Alliance. And today is our webinar on familial hypercholesterolemia. We are going to record this session, and so we can share it with attendees and also people that have signed up and aren't able to attend today. In addition, we're going to upload it onto our website. So if you want to revisit the session or ask your colleagues if they want to watch it, then it will be available. We will send the link out afterwards. But for this reason, can we ask that during the presentation, if you can keep your cameras off and make sure that your microphone is on mute, then that would be helpful. Otherwise, you might see your Facebook on the your face rather on the webinar recording on YouTube. If you've got any questions, please put them in the chat, and we've got time for questions at the end. And what we'll do is we won't put the questions in the recording. We'll edit those out because I wouldn't want anyone to feel sort of self-conscious about asking a question, thinking that it might be on our recording. So we will omit those from the recording when it's uploaded. So do ask your questions, put them in the chat. And if you haven't already, if you've only just joined us, you'll see there's a QR code on the screen. If you could use your smartphone just to scan that and complete our pre-event survey, that would be really helpful. It just gives us some information about who you are, where you've come from, and what your level of genomics knowledge is. And then we've got a survey for you to complete at the end just to get some feedback. It also gives you an opportunity to sign up to our newsletter so you can hear about future events and developments in genomics, which hopefully you'll all be interested in. So I think I'll just give it a second. We've got quite a few people on the call now, so maybe next slide. And thank you. So I'm just going to hand over to Elaine George. Elaine is the head of the West Midlands Familial Hypercholesterolemia Service. Her contact details are there. They're also on the end of the slide as well. So I'm now going to hand over to Elaine. Thank you, Elaine.
Thank you, Karen. Welcome, everybody. It's great to see so many of you here and wanting to hear about my favourite subject, familial hypercholesterolemia. So as Karen said, I'm the head of the West Midlands FH service. We're really fortunate in the West Midlands in that we set up a nurse-led regional service back in 2016. So all patients with suspected FH are referred to our service for assessment and offered genetic testing if FH is indicated. And obviously we're going to cover that a lot more during today's webinar. I'm a nurse by background, still registered of course, and spent a lot of my career working in cardiac intensive care and also cardiac transplantation, and saw a lot of young patients coming through that had had cardiac events that required stents, bypass and sometimes transplantation. And we saw a lot of patients that had a family history of early coronary heart disease. So when the opportunity came up to work with patients that had got elevated cholesterol with family histories of early heart disease, I was really interested in working with these patients to try and reduce the risk of them progressing to that point where they would need intervention, as are a lot of the families that we see in our service. So I'm going to tell you a little bit more about our service as we go through. The focus isn't on our service per se, it is on FH, but I will just talk a little bit about how our service runs as we go through the webinar. So the objectives of today's webinar are, I'm going to cover what familial hypercholesterolemia is. I am going to abbreviate it to FH for obvious reasons. It is quite a mouthful. We're going to talk about the clinical presentation of FH. I'm going to talk about the genetic testing process for patients and their families. We're going to talk about cascade testing, which is something that we do routinely if we identify somebody in the family that's affected with FH. And then towards the end of the webinar, I'm just going to go through a couple of case studies with you so that you can see the benefit of cascade testing for some of the families and how many patients we end up actually testing from one individual that is referred by a clinician into our service. So where does FH fit in terms of national priorities? So this is a slide that many of you may have seen before. It sets out the CVD ambitions for England. This is a slide from Public Health England, and it talks about the ABC work stream. So atrial fibrillation, high blood pressure and high cholesterol, and what NHS England's ambitions are for reducing the risk of cardiovascular disease over the next 10 years, and what interventions they're putting in place to try and do that. So in terms of atrial fibrillation and high blood pressure, it's all about identification. But our focus today is obviously on cholesterol, even though we know that high blood pressure and high cholesterol are very closely associated, and we will talk about that in today's webinar as well. So given that the majority of CVD cases are preventable, there's a huge opportunity to make a difference in improving CVD outcomes with this 10-year ambition for England. So in terms of high cholesterol, they're aiming to do NHS health checks or cardiovascular risk assessments on 75% of patients aged 40 to 74. That includes those patients having cholesterol readings and treatments initiated if their risk is considered elevated. They are also looking to increase the prevalence of FH from the current 5 to 7% to 25%, given that it is a fairly commonly inherited metabolic disorder. That is a significant number of patients that still need to be identified, and that's something that most areas are working towards, and we certainly are across the West Midlands. So what is the actual scope of the challenge in terms of FH? So FH is an autosomal dominant lipid disorder, and I'm going to talk a little bit more about the inheritance pattern as well during this webinar. And it affects approximately 1 in 250 to 1 in 280 people. So it is one of the most commonly inherited metabolic disorders, as I said. Around 5 to 7% of cases are known nationally, so the majority of patients are undiagnosed and are therefore untreated. And as I've just shown on that PHE slide, the long-term plan ambition is to increase the prevalence to 25% nationally. Children born to unaffected parents have a 50% chance of inheritance, and I will show you a little bit more about that as we progress onto the inheritance slide. And what we see, and general practitioners and anybody that works in cardiovascular disease management areas, we see families that are trapped in a cycle of developing premature heart disease generation after generation, and they don't really understand why. And in some of the families that we see, they almost accept that this is what happens, and unfortunately developing cardiovascular disease is their fate. But we know that we can actually do something about it by identifying patients as early as possible. So what is FH? So for the majority of the population, our cholesterol increases as we get older, due to aging, due to lifestyle, and for ladies, due to menopause. When females go through the menopause, generally their cholesterol levels will increase as well, because estrogen has some cholesterol regulating effect. And obviously, as our estrogen drops off when we go through the menopause, we do see a significant increase in cholesterol levels. The difference between hypercholesterolemia, which is raised cholesterol, and familial hypercholesterolemia, which is inherited high cholesterol, is that familial hypercholesterolemia confers a lifelong risk of premature cardiovascular disease because of lifelong raised cholesterol levels. So as I said, for the majority of people, cholesterol increases as we get older due to aging and lifestyle. But individuals with familial hypercholesterolemia have a mutation on one of the cholesterol controlling genes, and therefore they have lifelong raised cholesterol levels. So we know that lifelong raised LDL cholesterol in particular is associated with the onset of early heart disease. So we generally see early CHD or early CVD in these families. Untreated FH leads to a markedly increased risk of CHD, as I've just said, greater than 50% risk of CHD in men by the age of 50, and at least a 30% risk of CHD in women by the age of 60. However, there are very effective treatments, and we have more lipid-lowering therapies available now than we've ever had before. So with effective treatment, it can reduce the risk of mortality to that almost of the general population, especially in those that haven't already started to develop coronary heart disease. So if we pick somebody up really early, say in childhood or in early adulthood, for example, and they started on risk reduction treatments, so lipid-lowering therapies, we know that we can reduce the risk of mortality to that of almost the general population. So it seems an odd thing to say when we're talking about a genetic disease, but it is a modifiable risk factor for cardiovascular disease, because with effective treatments, we can significantly reduce the risk of these patients and their families developing cardiovascular disease. So what is the relationship between elevated cholesterol and atherosclerosis, atheroma, hardening of the arteries? As you all know, there's various terminology that describe the process of atherosclerosis. So this diagram shows the progression of atherosclerosis if the risk factors are not addressed. And obviously with lifelong raised LDL cholesterol, if it's left untreated, you would expect plaque formation to occur. So you can see the progression there from a normal artery to a plaque formation to growth of that plaque and sadly eventual rupture, which can lead to a cardiac event, and also blood clot formation. So the longer the cholesterol is elevated, the more likely it is that these plaques will form. Hence, patients with lifelong raised cholesterol, as is the case with familial hypercholesterolemia, the more likely the risk of them developing coronary heart disease or cardiovascular disease. Because obviously this doesn't only occur in the coronary arteries, it can occur in the cerebral arteries, and it can also occur in the peripheral arteries. So cholesterol plaque causes your arteries to become hard and narrow, so your heart has to work much harder to pump the blood through them. And as a result, we also see significant increases in blood pressure. So with patients that have FH that is left untreated, we often see that they have hypertension as well. And we know that high blood pressure and high cholesterol are two of the main causes of early heart disease. So how is FH inherited? So if you look at this diagram, this explains how heterozygous familial hypercholesterolemia is inherited, and that is where a child inherits a mutation from one parent. So they have an alteration on one set of their chromosomes. So if you look at this diagram, for the purpose of this diagram, it states that the father is affected with familial hypercholesterolemia. So the orange gene is a normal gene and the blue is mutated. For the purpose of heterozygous FH, and in this diagram, the mother is unaffected. So when this couple go on to have a child, depending on which set of chromosomes that father passes on to his child, depends on whether they will be affected or not. So you can see on the left and the right of the 4 children at the bottom of the slide, you can see that the boy to the left has inherited the mutated gene from his father, as has the girl on the right hand side. Now this is an autosomal dominant condition, so it can be inherited from one parent, and the affected gene and chromosomes overrides the unaffected set, and therefore the child is affected with the condition. I said to you earlier that each child born to an affected parent has a 50% chance of inheritance, and that all depends on which of the sets of chromosomes are passed on. So the 2 children in the middle both inherited the normal unaffected gene from dad, and obviously an unaffected set from mum, because she's not affected with FH, and therefore they have been born without the condition. Now, there is another form of FH, which is known as homozygous FH. So it could be that both parents are affected. Certainly in consanguineous families, we see this where blood relatives marry and they can both have the same gene alteration. And then the chances are that they could both pass that on to the child. There's still only a 50% chance of inheritance, but if mum passed her affected set of chromosomes onto the child and dad passed his affected set of chromosomes onto the child, then the child would have 2 affected sets. So when they go on to have children, that child has a 100% chance of inheritance because both of their sets are affected. So FH national guidance. So there's lots and lots of guidance at the moment that encourages regions, ICBs, general practitioners to identify and refer patients with suspected familial hypercholesterolemia for all of the reasons that I've just outlined. Obviously, what we want to do is identify these families, get them onto risk reduction treatment, and try and break that cycle that they are trapped in of developing heart disease at a young age. So we have the NHS long-term plan, which I've covered, which talks about increasing the national prevalence. We have an NHS health check programme, which is mandated through local authority public health teams. So all patients between the ages of 40 and 74 who aren't on a CVD risk register should be called into their GP surgery or an alternative provider at least once every 5 years and have a full cardiovascular risk assessment. So lipid levels are done as part of that, and they will calculate an individual's risk of having a heart attack, stroke, developing diabetes, vascular dementia in the next 10 years, and get them onto early treatment, which is more often than not, it would be initiation of statins or an alternative lipid-lowering therapy. General practitioners are also incentivised to systematically interrogate their primary care systems and identify patients who are at risk of FH, and I'm going to talk about how we do that later on in the webinar. And there are also 2 quality and outcome framework indicators in general practice, which look at treating patients to a suitable target, an LDL target, so driving the LDL down as much as possible, and also identifying patients and getting them onto statins, or where a statin is declined or clinically unsuitable, another lipid lowering therapy. We also had a child parents, we have a child parent screening programme, which is coming to an end at the end of September. It's been a pilot for the last 2 years, where children that go into general practices at the age of around 13 months for vaccinations are offered a heel prick cholesterol test. And if the parents consent to that, and then the cholesterol is identified as being elevated, a sample is sent directly from the GP practice to the genetics laboratory to see if the cause of that child's underlying elevated cholesterol is due to familial hypercholesterolemia. So it was a pilot that is coming to an end at the end of September, and then there will be an evaluation phase, and NHS England will make a decision as to what will happen with regards to the child parent screening and the commissioning of that from April next year. We also have a genomic test directory where FH is part of that genomic test directory. So FH genetic testing is available through the genomic laboratory hubs across the country nationally, and it is funded by NHS England. So there's certainly a lot of policy with regards to familial hypercholesterolemia identification, active case finding, which is something that we do in our service. There's also 2 sets of NICE guidance. One is not specific to FH, it's the cardiovascular disease risk assessment and reduction guidelines, which were updated last year. And then there is CG71, which is specific for the identification and management of FH. So in terms of the NICE CG71, that guidance was released in 2008, and they updated that guidance in 2019. And back in 2008, NICE broadly outlined 5 objectives of a FH service. That was to identify those at risk of carrying an FH gene, so the detection, to undertake genetic testing for those considered appropriate, to undertake cascade genetic testing for appropriate relatives of those with confirmed FH, and I'm going to show you an example of how cascade testing works in our service, to manage those with monogenic FH, and to do so with the most cost-effective use of primary and specialist care, and to manage the majority of those with polygenic hypercholesterolemia in primary care. So that guidance, as I said, was released in 2008 and updated in 2019. And we still have significant variation across the country as to how FH services run. Not many areas have regional nurse-led services such as ours. There are several, but certainly the whole country, unfortunately, isn't covered by a robust service. So there is still some significant variation despite NICE releasing that advice back in 2008. So how do we detect FH? So there is a considerable overlap in LDL cholesterol levels between those with monogenic FH, so those with confirmed genetic FH, and the general population. And there is no level of LDL cholesterol that is perfectly sensitive and a specific cut-off point. But generally, the higher the LDL cholesterol level, once secondary causes have been excluded or treated as far as possible, and lifestyle factors addressed, the higher the chance of monogenic FH. So there's various risk stratification tools that are used in general practice and in secondary care to identify patients with possible FH. So just a few examples of those are the Dutch lipid score. I'm going to cover the Simon Broom criteria, which is one of the oldest criteria that we still use, and I'll go through that with you. And then more recently, the All Wales FH service have got a revised version of the Dutch lipid score, and they do an age-adjusted score to try and risk stratify patients to identify if FH is likely, because as I said, there is a considerable overlap in LDL cholesterol levels between those with monogenic FH and the general population. So we can't just test everybody that has elevated cholesterol. We need to try and risk stratify so that we are only offering testing to those patients that are likely to have FH. I'm just going to go forward and show you the Simon Broom criteria. So this is a set of clinical criteria, and this is how patients were always diagnosed with FH until we had access to genetic testing. So patients were clinically diagnosed with FH pre-genetic testing being widely available, as it is now through the genomic laboratory hubs. So the criteria is, in the Simon Broom criteria, is a cholesterol higher than 7.5 or an LDL above 4.9 in an adult, and a cholesterol higher than 6.7 or an LDL above 4 in a child under the age of 16 years. Plus physical presentation, so attendance anthemata in the patient or the first degree relative, and I'm going to go through the clinical presentation with you. Plus a family history of myocardial infarction before the age of 50, it says in the Simon Broom criteria, or 50 in a second degree relative, or 60 in a first degree relative, or a family history of raised total cholesterol. Now, as I explained earlier, generally patients that have familial hypercholesterolemia do have a family history, quite a strong family history of early heart disease. We certainly don't see that with every patient and family that we see. But the one thing to always remember is that there will always be special circumstances such as adoption where the family history can't be ascertained, or a first degree relative has been identified already with a known FH causing genetic variant. So we would then go on to cascade test. So my advice would always be, if you have a patient that has significantly raised lifelong LDL cholesterol, so if you've had access to historic bloods and you can see that their cholesterol has always been elevated, it hasn't increased over time, and there is no family history of early heart disease because the patient's been adopted or because they don't know very much about their family history, then we would always err on the side of caution in our service and offer testing anyway. So as I said, there are various different risk stratification tools available, but the Simon Broom criteria is a really good starting point, and a lot of patients were diagnosed with FH this way, using a clinical diagnosis rather than genetic testing before it became widely available. There is variation within the risk stratification tools. So the Primary Care Network DES, which is the incentivisation scheme for general practitioners to systematically search their registers and refer patients in for genetic testing, the threshold for that was set quite a bit higher, so that the GPs were incentivised to actively look for patients aged 30 or above with a total cholesterol greater than 9 millimoles per litre, or age 29 or less with a total cholesterol of 7.5 millimoles per litre. And the benchmark was raised a little bit because we just knew that there would be a significantly higher number of patients to access genetic testing if the cholesterol was set at 7.5. It also says to exclude secondary causes of elevated cholesterol. So in our service, we test patients with concurrent triglycerides less than 4.5 millimoles per litre, because if you have patients with significantly elevated triglyceride levels, then that is likely the cause of their increased cholesterol levels, because the triglyceride levels will be what are increasing the cholesterol levels. So that is where we want to exclude secondary causes of high cholesterol. Now, the secondary causes are here. So if you have somebody that has raised cholesterol, also has raised triglyceride levels, before you refer them in for genetic testing, you need to rule out the secondary causes. So do bloods for hypothyroid, do a HbA1c on the patient. Does the patient have CKD? Does the patient have nephrotic syndrome? Is the patient pregnant? So we do see significantly increased cholesterol levels as a result of changes of hormones during pregnancy, particularly in the third trimester. So we would always encourage that patients' cholesterol levels are rechecked postpartum unless their cholesterol levels were elevated pre-pregnancy. So if the patient had increased cholesterol levels before they were pregnant, we would happily offer a genetic test in our service. But if it was a lipid level that was taken during the pregnancy, then we would encourage that they wait until the patient has delivered the baby, and then about 3 months postpartum, check the cholesterol levels again. We do not advocate patients having lipid lowering therapy during pregnancy, so they're not going to come to any harm anyway by waiting 3, 6, 9 months to have their cholesterol rechecked. Other causes of increased triglyceride levels, which can also push the cholesterol levels up, are excess alcohol intake, chronic liver disease, and certain medications that are outlined there. So anabolic steroids, atypical antipsychotics, and immunosuppression. When you are assessing a patient to re-stratify them for their likelihood of having FH, patients should also have a physical assessment. Now, I'm not saying that this needs to be done in every service, but certainly in specialist services such as ours, we do a physical assessment on the patient. So we're looking for any signs of corneal arcus. So you can see on this picture of this patient's eye, they've got an evident ring around the cornea, and this is a buildup of cholesterol around the eye. Now, this does occur in about 60% of individuals between the age of 50 and 60. So when it occurs under the age of 40, it may be associated with a lipid metabolism disorder such as FH. It is a fairly difficult indicator due to patients not always knowing the age of onset. So if we see a 60-year-old, for example, that has corneal arcus, it's very difficult to determine whether it was premature, so occurred under the age of 40, or whether it's something that's occurred more recently. You can see here on the left-hand side of the slide, there is a picture of some thalassemia around the patient's eyes. So this is a fat buildup under the skin, and you can also get some deposits in the tendons, more commonly the Achilles and the tendons across the knuckles. So we look for physical signs. Now, if the patient doesn't have any physical signs, it certainly doesn't mean that they don't have FH, but if they do have physical signs, then FH is more likely. So I did say that I was just going to talk a little bit about our regional model. So we cover a population of around 6 million patients. We serve the West Midlands and Oxfordshire. We're a nurse-led service. So all patients that are identified in general practice or by our lipid consultants with possible FH are referred into our service for assessment and testing. We have approximately 1 FH nurse to a 1 million patient population, and we accept referrals from all specialties. So we will accept referrals from cardiology, cardiac rehab, pharmacy, nursing, general practice, and lipid specialists. So once we've received a referral, we do re-stratify the patient based on the information that's being provided to us. And then if we think that FH is indicated, then we will invite patients to an appointment at a location of their choice. All our clinics take place in primary care, so none of them are hosted in secondary care other than in Oxford. We've got a slightly different delivery model across Oxfordshire. So when we see the patients in clinic, we assess the patient for the possibility of FH. So we look for physical signs as per the previous slide. We ask them about their family history, and we draw a comprehensive family pedigree. We will give the patient lifestyle advice and refer to lifestyle services where they're available. And then if we think that FH is still indicated, we will talk to the patient about having a genetic test and the implications of that on themselves and for their family members. So we talk to them about cascade testing. So we explain to the patient that if they do have a confirmed diagnosis of FH after genetic testing, that we will also offer testing to other potentially affected family members. And that's one of the reasons that we draw a comprehensive family pedigree. One is to look at any patterns that may emerge, so to see if there are any patterns of early coronary heart disease on either the maternal or the paternal side of the family. But it also gives us information about who else in the family needs to have genetic testing if we get a confirmed diagnosis. All patients in our service sign a consent form to have genetic testing, which just talks about DNA and the storage of DNA after testing. And then we facilitate the cascade testing process for patients that live in area and out of area. And I'll explain a little bit more about that when we look at a case study. So when we get a report back from the laboratory, so we send a blood sample off to the genetics laboratory for our index or proband patient, so the first patient within the family that's tested. We send a blood sample off to identify if the patient is affected, and if they are, which gene the mutation is on. It takes around 6 weeks to get a result on the first patient, the index or the proband. And then once we get that result back, we get one of 3 outcomes. So we either get FH confirmed, or we get a monogenic cause is not identified, so the patient doesn't have familial hypercholesterolemia, or we get an outcome of a variant of uncertain significance. So in a very small percent, about 2% of our West Midlands patients that we've tested have an outcome of a variant of uncertain significance. So this is where the laboratory have identified a change, but there isn't enough evidence at that moment in time for them to say definitively whether that variant is the cause of raised cholesterol and early heart disease within that family. What happens over a period of time, and we have seen this happen quite frequently with our families, is that as the evidence base builds with regards to that variant, then the variant is often reclassified then as FH causing either likely pathogenic or pathogenic. So in that instance, we would then contact the family, advise them that evidence base has emerged with regards to that particular variant, and that the gene has reclassified and the patient now has confirmed FH. So this is an example of an FH confirmed genetic report. So where it says the reason for testing, on our standard report, it would have all the patient's details at the top. So obviously name, date of birth, NHS number, etc. And then it says the reason for testing. So the reason for testing is to investigate the cause of the patient's hypercholesterolemia. The results summary here confirms a genetic diagnosis of FH. And then the result states that that patient is heterozygous for a pathogenic, and then it will name the gene variant. So in this case, it's an ApoB. It's a variant on the ApoB gene, and it's a missense variant. So if you go down to the recommended action, it says referral of this individual to a specialist lipid clinic may be appropriate, and that is in accordance with NICE CG 71, which suggests that all patients with a confirmed diagnosis of FH should be referred to a lipid clinic for assessment and management of their FH. And then once they are stable on their lipid-lowering therapies, they can be referred back to primary care for ongoing management. And then it says testing of other family members for the ApoB variant is available, either via referral to a specialist lipid clinic or clinical genetics, or in our case, we do this within our service. And then it tells you a little bit about the variant details. So it tells you which gene is affected, the location of that gene, the zygosity, so is it heterozygous or homozygous, and also the classification. So in this case, it's pathogenic. So there is enough evidence to confirm that this is a disease-causing variant. Bear with me, sorry, I've lost where I am. Yep, so there are SNOMED codes for those of you that work in primary care. There are SNOMED codes available to record the outcome of either an FH genetic test or an assessment for FH or a referral for FH. So these can be documented in a patient's notes so that you don't keep revisiting those same patients. These SNOMED codes were only released last year, so they are fairly new, but there's various codes, as I say, one for assessment. So if you've assessed the patient but not referred them, if you've assessed them and then identified that they've got secondary hypercholesterolemia, you can record that. And then if you've referred them for assessment, you can record that. And then there are various codes for heterozygous, homozygous, polygenic hypercholesterolemia. So in a lot of cases, that's monogenic, not confirmed. Some laboratories will report on polygenic risk scores, but not all of the GLHs do that. And then there's a variant of uncertain significance SNOMED code as well, so that we can accurately record who has been tested within a GP practice. And that's certainly important from a national perspective as we try and move towards that 25% identified prevalence, because this will help us to measure that through the CVD Prevent audit, which some of you may be familiar with. So key learning points. FH is characterised by lifelong raised cholesterol levels. Therefore, it's not usually indicated in patients whose lipid levels have previously been in a normal range. So if you see patients where the cholesterol levels were once 4, 5, 6, and they've increased over time, then it's highly unlikely that that patient has familial hypercholesterolemia. Cholesterol levels can rise considerably in postmenopausal women, so it is always useful to have historic lipid levels. So as I put there, review historic lipid levels and concurrent triglycerides just to eliminate secondary causes of high cholesterol, and family history is key. If you don't know the family history, then it's always worth erring on the side of caution so that we don't undertreat or undertest that family. Lipid levels can rise during pregnancy, always exclude secondary causes of dyslipidemia. Family history of early CHD is likely, so under the age of 60 years. Refer patients with an FH or probable FH diagnosis coded entry who have not previously been tested. So if you work in primary care and you have patients with a clinical diagnosis of FH, but they've never had a genetic test, they may be treated to target with their lipid lowering therapy, but it's always worth referring them in, because what we can then do is cascade test the family members, and obviously we've just evidenced the benefits of that with the case studies. So if you've got patients with a clinical diagnosis but not a confirmed genetic diagnosis, even if their lipid levels are fine because they're on treatment, then they should definitely be referred in for genetic testing for the benefit of their family members and for confirmation of diagnosis. I always say, one of the questions that we get asked a lot is if we are referring patients for genetic testing and they are eligible for lipid lowering therapy, should this be initiated prior to referral? And the answer to that is a definite yes. Lipid lowering therapy should be initiated at the earliest opportunity in accordance with NG 238. So that's the CVD risk assessment and reduction at that point, because the patient won't have a diagnosis of genetically confirmed FH. So always initiate statins at the earliest point that you can. That's it from me. We're going to go over to some questions. So I'll stop sharing the screen and then I can answer any questions any of you may have.